Hello everyone and welcome back to my playlist of 10 Teachers Gynaecology. We will today do chapter number 8. My name is Professor Asif Qureshi and you are watching Dr. Asif Lectures. Now this chapter from 10 Teacher Gynaecology basically deals with the state of menopause, which is the physiological stoppage of the menstrual cycle in a female. Obviously, the end of reproductive age, which we will discuss in a minute, उसको हम कहते हैं menopause. No more menstrual cycles, no more ovulation, no more fertility. Okay, and the reproductive health after this particular period, यानी इसकी एक age bracket होती है. So, for example, many of the females have this menopause between the age of 45 and 55. तो एक दफ़ा अगर इसमें से किसी भी एज ब्रैकेट के बीच में कहीं भी बास फीमेल्स में अर्ली थोड़ा अगर है तो 45, 50, 51, 52 किसी भी एज पे मेंस्ट्रुअल साइकिल्स विल स्टॉप. और उसके बाद का जो एरिया है दैट इज टर्म्ड एज पोस्ट रिप्रोडक्टिव हेल्थ. पोस्ट क्योंकि बाद में रिप्रोडक्टिव यानी अब रिप्रोडक्शन नहीं हो सकती, सो पोस्ट रिप्रोडक्शन आफ्टर रिप्रोडक्टिव area, what are the health concerns in a female, and this is very important because throughout the menstrual cycle female is going through a lot of hormonal stuff ना. estrogen release हो रहा होता है हर वक्त, और then progesterone is there, and these things are very important for metabolism in the females. So once the menstrual cycle goes away, then the hormonal changes are all collectively known as post रिप्रोडक्टिव हेल्थ. सो फिर बोन्स पे इफेक्ट होते हैं, कार्डियोवास्कुलर सिस्टम पे इफेक्ट होते हैं, वो सब हम पढ़ेंगे इस चैप्टर में, राइट. सो लेट अस फर्स्ट टॉक अबाउट व्हाट आर द लर्निंग ऑब्जेक्टिव्स. दे विल बी बाय द एंड ऑफ द लेक्चर द स्टूडेंट्स शुड बी एबल टू नो द डेफिनेशन ऑफ मेनोपॉज. होता क्या है, हाउ डू यू डिफाइन इट. सिर्फ ये कहना काफी नहीं है कि मेंस्ट्रुअल साइकिल का रुक जाना. मेंस्ट्रुअल साइकिल तो प्रेगनेंसी में भी रुक जाते हैं, बट दैट्स नॉट मेनोपॉज. ओके, अंडरस्टैंड द फिजियोलॉजिकल एंड नॉन फिजियोलॉजिकल रिस्पॉन्स of the body, obviously, in menopause. Understand the effect of menopause on women, उसकी bone health पर, cardiovascular health पर, general metabolic health पर. Understand the modifiable and the non-modifiable aspects of the menopause, what you can work with, what you can modify, what you cannot modify, what's not in your control. Explain the main forms of treatment for menopause, what medications are available to help the female survive better in the post-reproductive area, and know the side effects of the medicines and the contraindications and the indications of hormone replacement therapy. So very, very common. Many females approach your clinic asking for help and advice regarding their menopausal and post-reproductive age time period, right? You should be able to then understand all of them, also the benefits of HRT, hormone replacement therapy. So with all these objectives in place, let us begin with the definition. Menopause is defined as the women's final menstrual period, and the accepted confirmation of this is made retrospectively after 1 year. So एक साल का टाइम यानी मेंसेस बंद हुए एक पर्टिकुलर एज ब्रैकेट में जो 45 से 55 यूजुअली होती है. इस एज ब्रैकेट में अगर फीमेल कम्स टू यू कि मुझे एक साल से मेंसेस नहीं आ रहे, दैट्स काइंड ऑफ अ confirmation for menopause. So that's how it is defined. The cause of menopause is cessation of regular ovarian function. So ovary ceases, और ovary cease इसलिए करती है क्योंकि ovary में जो number of follicles होते हैं they decline. मैंने आपको ये पहले भी बताया है earlier chapters में कि at the beginning the ovary is full with like millions of ovum, and then they decline. ovary में hormonal system है ना, inhibin वगैरह मौजूद हैं, so they kind of inhibit the ovarian system, and with the passage of time these decline, and ultimately females reach an age where they are almost finished, right? So there is no ovarian follicles to respond to FSH and LH. So this is all empty ovary, and this is where menopause happens. Okay, so this is what it is. Now, these are some terminologies. The word menopause, we talked about it, the last menstrual period. Give it 1 year for confirming and for definitive understanding of menopause. What is perimenopausal time? It's the time of the life from the onset of the ovarian dysfunction until the 1 year, यानी जब से बंद हुए हैं, and then 1 year पूरा ये जो time period, that's called perimenopause. Perimenopause मतलब around menopause. Postmenopause is after the menopause. 1 year has been elapsed completely. So ये जो perimenopause area है, ये obviously इसमें menses फिर भी आ रहे होंगे, but post menopause में once the menses stop 1 year after that. Okay, and the change is the colloquial description of the perimenopause and the postmenopause. So suppose, for example, if there is a female who finishes her menstrual cycles at the age of 48, तो perhaps 46, 47 की एज से ovarian function decline होना शुरू हो गए होंगे. So that is the perimenopausal area, और 48 पे stop हो गए तो इसके बाद का एरिया जो है वो postmenopausal area है, और इनको combine मिला के हम नाम देते हैं the change period. Now, what is the physiological menopause? The timing of the menopause. The average age of menopause worldwide has not changed for decades. It's been there for a long time. Perfect median age जो है उसकी 51-52 है, and 95% of the females stop their menses between this bracket, 45 to 55. That's the age bracket for 95% of the females, right? And this is where the ovaries are devoid of their reserves of ovum. Okay. Now एक टेबल इन्होंने यहाँ पे दिया है, so this is the table. इस पे आते हैं थोड़ी देर में, पहले ये थोड़ा डिस्कस कर लें तो वो फिर क्लैरिटी के साथ समझ में आएगा. Now, what are the endocrine changes which happen during the menopause? Current understanding is that the menopause occurs at the time of depletion of oocytes from the ovary. So, ovary khali ho gayi, oocytes khatam, right? And this is irreversible. Groundbreaking and yet to be widely accepted research challenges this assumption with the finding of oogonial stem cells. So now researchers believe that although ovary ke andar ova finish ho gaye, but there are stem cells, they can be stimulated, they can be converted. So they're trying to kind of work around it, and this may influence the timing of menopause, but so far no progress on that. I would say still menopause happens, and this is the age bracket where menopause is noticed. Okay. Unsurprisingly, the endocrinology is not as simple as the ovaries just running out of eggs and the capacity to produce hormones at a particular age. Chapter 3 में जैसे हमने discuss किए थे different hormonal controls of the menstrual cycle, starting from the FSH to LH to all these, बल्कि इससे भी पहले gonadotropin releasing hormone. So you remember the hypopituitary ovarian axis, वो पूरा axis जो है disturb होता है, right? So the hormone control of the menstrual cycle and the hormone disorders, reproductive function is maintained by subtle interplay of the GnRH release, the pituitary hormones, the FSH and LH, and the ovarian peptide hormone inhibin B, and the steroid hormones, which are estrogen, progesterone, and testosterone. Yes, female produce this. These hormones not only change during the menstrual cycle, but also thought throughout a woman's reproductive life, with their production changing at different times. So we know that these hormones are all very important for running the normal reproductive age and ovarian cycle and the uterine cycle. Okay, inhibin B is produced by the follicles within the ovary. So as the number of follicles decline, the production of inhibin decreases. In the perimenopausal years, a small decline in inhibin drive an overall increase in the pulsatility of GnRH, and FSH and LH levels go down as well. And the androgenic hormones, which come from the ovaries primarily, also in the periphery from the adipose tissue and the adrenal gland, with the ovaries producing about half of these hormones. So if ovary function is stopped at menopause, half of the enzyme, मैं बात कर रहा हूँ about androgenic enzymes, hormones, not enzymes, sorry. Androgenic hormones, which are estrogen and progesterone, their levels go down. So if you look at the table here, this should now make sense. So GnRH, FSH and LH, these are all coming from the hypothalamo-pituitary ovarian axis, and they reduce with menopause. Okay, estrogen and progesterone, they decline during menopause, but obviously you also keep on producing them from other resources such as adipose tissue, such as from adrenals. Okay, inhibin becomes undetectable because ova are all gone, and testosterone also have very low levels because this is alongside these two. This is also an androgenic hormone. So the androgenic hormone are being produced from other sources, but जो काम ओवरी में होना था वो तो हार्मोन सारे गए, right? How do you diagnose menopause? The diagnosis is largely clinical. I mean, female comes to you and tell you that there are no menses for X amount of time, and this is how you diagnose it, right? So there's no like कोई test वैस्ट इसमें नहीं कर रहे होते आप basically. The use of serum endocrine tests such as hormone levels और ये, I mean, they're little value. You don't do it. Menopause में ये investigate नहीं करते आप आमतौर पे. In all women whom a diagnosis of menopause is being considered, the possibility of pregnancy should also be considered. The special circumstances of diagnosis of menopause in a woman who has undergone hysterectomy can be difficult due to lack of signaling bleeding. So again, the bottom rule being that whenever any patient comes to you with any complaint, you obviously have to take a very good history. So agar female aati hai ji menopause ke saath, you will obviously undertake history, and this is where you will get to know if any hysterectomy is done or any previous surgical history is available or not. So what is the primary cause of menopause? So if you assert and this is a physiological menopause, the female is at the age of menopause bracket 45 to 55, then this is where you start considering, और एक साल हो गया है कि जी menopause की definition confirm हो रही है. Okay. What is non-physiological menopause? So this is physiological. If someone reaches this age bracket, 45 to 55, and they stop bleeding, this is something normal. This is something physiological. But sometimes there is premature ovarian insufficiency. So for example, before the age of 40, all the ova are gone, and this is no menstrual cycle before the age of 40, and this is what we call premature ovarian insufficiency. Okay, also called premature ovarian failure or premature menopause. These are all the different terms that we use. It is thought to occur in approximately only 1% of the female under the age of 40 and 0.1% under the age of 30. So menopause is even also reported as early as 30 years of age. It is a distressing diagnosis for a woman to receive. Obviously, consider a female who is just 30 comes to know that no more ova, no pregnancy. Oh my God, that's a devastating news. Premature ovarian insufficiency is usually diagnosed following either primary or secondary amenorrhea. People come to you, females come to you with amenorrhea. They are so young, so they do not consider that they have menopause. They think they are pregnant if they are sexually active, but upon investigation, history taking, and all the now this is where the laboratory investigations of FSH and LH may be helpful. So once you diagnose this is primary ovarian insufficiency, this is a hell news for patients. Obviously, while no cause is found in most cases of primary ovarian insufficiency, there are suspected investigation जो आपको इस लाइंस पे करनी है. So for example, you check for any chromosomal abnormalities such as Turner Fragile X, any autoimmune disorders such as hypothyroidism and Addison's, even myasthenia, and some enzyme deficiencies. They can lead to primary amenorrhea or primary ovarian insufficiency. अब जैसे इनमें से Turner's है, they have streak ovaries. इनकी ovaries they are kind of fibrous, so no normal structures, and this would lead to primary ovarian failure and primary amenorrhea perhaps. There are some secondary causes such as chemo and radio, infections such as TB, mumps, malaria. So female was absolutely fine, but because of some other cancer, she underwent chemotherapy or radiotherapy, and the ovaries are they are boomed out, and there are no ova. So this is then the secondary ovarian failure. So obviously you'll be investigating the patient with history, with examination, with investigations, and you have to make a confirmed diagnosis if you are to diagnose premature ovarian failure. Okay. Iatrogenic menopause, what does that mean? Well, there is an increasing array of non-surgical treatments that result in iatrogenic or temporary or permanent iatrogenic menopause, and this is increasing in number. Modern screening programs, technologies to achieve early diagnosis, suspected malignancy, early radical treatment of female reproductive tract malignancy have contributed to this. So these are something where you are actually inducing it. Iatrogenic is by like medically induced, right? But obviously for you are doing treatment for some other thing, and now it leads to premature ovarian failure. Such women, especially those under the age of 40, must be carefully counseled as to what to expect prior to definitive irreversible treatment when she is managed as someone with POI thereafter. So the point is, if you are, for example, offering somebody chemotherapy, you have to discuss with them that they may end up having no ova, having no functioning ovary. Okay. If GnRH is given in constant high dose, it desensitizes GnRH receptor, reduces LHFS. So even GnRH treatment in high doses, continuous doses, may lead to shutdown of the whole system and lead to early menopause. Surgically, women may be placed into a surgical menopause, aiming to permanently treat benign gynecological conditions such as menstrual disorder, fibroid, endometriosis. So somebody having uterine problem, and you are doing removal of the uterus and bilateral perhaps salpingo oophorectomy, जिसमें आप uterus ovary भी निकाल रहे हैं इनफैक्ट ना. तो अगर इस स्केल का ऑपरेशन आप कर रहे हैं, then you are not expecting, because you are removing ovary oophorectomy. So ovaries are not there, they will not be working. Why you have done oophorectomy? To surgically treat a condition which was primarily affecting either ovary or uterus. So as a byproduct, as a result, there is premature ovarian failure. Okay. So there are also females who have high risk of certain cancers, ovarian cancers, and you have to do prophylactic oophorectomy, for example, if they are known BRCA1, BRCA2 gene mutation carrier. So if you are doing this procedure, you must discuss this with patient that this may lead to early menopause. So that's a very sufficient discussion about menopause, the endocrine changes. Remember, ovaries not working. This is what menopause is, because ova are gone, and why they are gone, we discussed various scenarios. Now we are going to focus more on post-menopausal reproductive health. So once menopause is established, how is the health afterwards? Okay, as the UK population expand, it is clear from data predictions from Office of the National Statistics that longevity is also going to increase. So people are having better health, they are going to live more, and then the problems of later ages are becoming common. The whole UK female population is projected to increase in 25 years between 2012 and 2037. From 32 million to 36.8, roughly around 37 million girls and women. The vast majority is accounted for by over the 50 age group. So we will soon be dealing with a lot of menopaused women, at least in the British society. So, and I think this is the case everywhere else as well. Also here in the US and in developing parts of the world, stays the same almost. This means that population of women who are likely to experience problems during their post-reproductive year is going to increase year by year for the next 25 years. So here you see women with menopause increasing by 2037. Okay, because this is the population which is over, I can't actually, well, this is the one that's the total population, but if you look at the blue line, this is the one with over 50 years, and this is increasing. Okay, medicine traditionally delivers healthcare in system and condition specific silos such as cardiology, gynecology, bone medicine. That's how it works, right? In a specialty, this is also sensible when it comes to delivery of specialist expertise, particularly to women's life and women's health. This may be described as continuum of the care. A good example of this approach is management of obesity in postmenopausal. So they're just trying to convince you that post-reproductive care is very, very important. Okay, in many countries it might not just be a problem, female age, they have menopause and then they are never going to clinic to consult for this time period. But in West, obviously they are very much concerned. They care for their bone health and all, so they are kind of emphasizing actually everyone should consult clinic for post menopausal or post reproductive era. How women are affected: the hormonal changes during and after the menopause have radical changes on the woman, substantial changes. The timing of when each system is affected not only varies dramatically between women, but also the degree of how changes influence each woman. So ये जो hormonal change है ना, they affect the women body quite a lot. So, for example, central nervous system, the vasomotor symptoms. Some of the earliest changes during the menopause is the onset and appearance of perimenopausal vasomotor or central nervous systems. And there are psychological changes. There are physiological and changes which the person, organic changes, for example. So in this time period of menopause, 0 to 5 years, there are hot flushes. Female suddenly feel hot. There are night sweats. So this is like organic symptoms. There are psychological symptoms, mood changes, and suddenly they are happy, suddenly they are very terrible. These mood swings are very, very common. Loss of concentration, poor memory, joint pain, dry and itchy skin, hair changes, decreased sexual desire. These are serious problems very early on during menopause. And then during 3 to 10 years, there's vaginal dryness, soreness, pain during urine, urgency of the urine, prolapse in the urogenital area, and long-term are osteoporosis, CVS problems, dementia. Guys, this is something serious. If you are a lady or have seen a lady who is in the menopausal area, you know what I'm talking about, right? This is serious and therefore it should be taken care of. The exact etiology of vasomotor symptom is unknown, but it is thought to be loss of modulating effect of estrogen. Estrogen is not there. So remember, this table is very, very important. कि कौन से hormone down हो रहा है? See, estrogen levels are going down, progesterone levels are going down, and this itself is enough for a lot of different symptoms that the female face during the post-reproductive era. Okay. Hot flashes occur in up to 80% of the women, with less than 30% seeking help. So, not only that this is very common, but the major problem also being that they are not coming to the clinics for help. Perhaps the most distressing effect of vasomotor symptom is through the occurrence of night sweats. The women may sleep at time of the sweat. During the episode, she can be fully woken of, or her level of sleep can be converted from deep rapid eye to shallow. So absolutely disturbing the female, these night sweats, right? While hot flashes tend to appear unpredictably, there are triggers such as alcohol, such as increased body mass index or caffeine, so they are more prone to have more hot flushes. Serious symptoms in the post-menopausal era. Then there are psychological symptoms. I told you about irritability, low mood, swinging mood, lack of energy, tiredness. These are all real. Then this diagram actually shows postmenopausal the women showing atrophic changes in the vagina. Look at the vagina here. Look at the vagina here, atrophied. Okay. Also, there are effects on the cognitive function. At present, there is no clear evidence that menopause is associated with acceleration or onset of dementia. Most women, however, complain of some changes in the memory, and there is global cognitive problem, right? उनको याददाश्त में थोड़ा मसला है. Now effects on the, so ये सारे effects थे mood changes and CNS के effects. Now menopause के effects on genital tract. So there are changes obviously in the menstrual bleeding. No more menstrual bleeds, right? This is a genuine issue. A female body is used to monthly cycles. Now no more cycles. They occur relatively soon during the process of menopausal transition. they मतलब अगर 45 पे menopause है तो पिछले कुछ महीनों से ही disturbed cycles में होना शुरू हो जाती है, right? But then ultimately they stop and they're no more there. So something is there for the whole life, starting from the age of menarche, and now it suddenly disappears. Itself is a psychological issue. Endometrial effects. The initial irregular or scanty vaginal bleeding is due to reduction in the estrogen, low estrogen, and this is indicative of low ova in the ovary, so less bleeding, right? Okay. Then the urogenital tract and vulvovaginal atrophy, vagina atrophies, the epithelium thins down, so everything is going down, right? ये भी जो मैंने आपको diagram दिखाई दी है. This is the whole paragraph that it is talking about. Now, the bone health, one of the best understood areas of long-term post-reproductive health is the changes in the bone. हमेशा जब आपसे पूछेंगे what are the effects of menopause on a women health, always divide them into intermediate effect, immediate effects, and long term. So long term there are osteoporosis, bone effects, and cardiovascular disturbances, right? To fully understand this area, it is important to be aware of the fact that the skeleton is maintained by constant process of remodeling, bone resorption and bone formation, okay? And this happens by osteoblast, bone formation, and osteoclast, bone resorption. The balance of the rates of resorption versus deposition is affected by many factors, and one of the factors is estrogen. So if estrogen is not there, less bone formation, so the bone's density goes down and there are more chances of osteoporosis. So this is why after the age of menopause, risk of osteoporosis is very high, and you must take care of that. Okay, so particularly at the age of 60, fracture of the hip and spine, it increases. Very common. Osteoporosis is defined as a skeletal disorder characterized by compromised bone strength. Okay. Some risk factor for osteoporosis. One of them is menstrual stoppage, right? Menopause, but others can be smoking, family history, premature ovarian insufficiency. That's the same thing as menopause, right? Immobility and nutritional problems and liver diseases. So there are so many problems for osteoporosis. Lack of estrogen or menopause is one of them. What are the effects on cardiovascular system? Effects of what? Effects of menopause, right? Approximately 30% of all deaths occur as a result of ischemic heart disease and stroke. That's the general statistics. This makes CVD a condition that significantly burdens the global health system. While management of CVD is not usually within the realm of the gynecologist, obviously it is taken care by the cardiologist. It is important to recognize that because many women seek help of gynecologists during their life, and you should know that there are menopause menopausal effect on CVD, so you should actually understand कि किस तरह patient identify करने हैं या refer करने हैं at the least. During the menopausal transition, there are several changes in the female physiology that can influence the risk of cardiovascular diseases, and they include the lifestyle issues such as nutrition and exercise, and changes in the obviously hormonal levels also, which changes a lot of lipid metabolic pathways, right? So levels of LDL, HDL, they go up and down in perimenopausal time. So how do you assess the menopausal women? The key to any consultation around menopause is not only to assess the impact of menopause, but also the opportunity to appraise the presence of other risk factors. Is she smoking? Is she taking a lot of alcohol, which is out of non-recommended dose and in the non-recommended range? And are there other like obesity or PCOS or other problems, other risk factors? So they all should be considered, okay? And based on a very good history, investigation, and examination, then you divide the risk factors into either modifiable risk factors or non-modifiable risk factors. So for example, lifestyle, just take this as an example. This is a modifiable risk factor. So you can improve the exercise, you can improve the nutrition, you can stop alcohol and smoking, and you can improve the sexual activities and contraceptives. So these are all modifiable factors. But then there are some factors which are just not modifiable. So if there are some, for example, genetic issues, you can't really control those, okay? So please understand and remember this. There is really a need of investigation to confirm the menopause. ये दूसरी तीसरी दफा जुमला आ गया है because this is important. आपने investigate करके इसको identify नहीं करने को disease नहीं है यार. This is the normal physiology, right? Menses stops at a certain age, and that's what it is. While the serum FSH level more than 30 is highly suspicious of menopause because this should go down, the diagnosis can be confidently made in most women based on the history alone. So you don't even check for FSH, okay? The moment a perimenopausal woman presents for an assessment as to whether she is menopausal or not gives an important opportunity for preventive healthcare, because she is here to identify and seek your guidance if she is in the menopausal area. But this is the opportunity that you as a healthcare worker should use to address all the issues associated prospectively once menopause is achieved. How do you manage? Obviously, diet and lifestyle changes. These are the modifiable risk factors. Stop smoking is number one. It is very good for a lot of other things as well. Reducing alcohol consumption, stop if you can, and get to the normal BMI range. So this is the first thing you do, diet and lifestyle changes. Then there are certain non-hormonal approaches of management, such as most women on experiencing the early symptoms of menopause will seek out a solution from wide range of alternatives and natural solutions which are available. So these are the kind of non-hormonal stuff, right? And you should be able to address those. These groups of treatment are widely available but very poorly researched in the scientific manner. So अब ये table देखते हैं क्या क्या चीजें हैं वो. When counseling a woman about taking natural hormones, it is important to make her aware that these are essentially weak hormonal replacement therapies itself, although that they are natural, but still there are some chemicals involved, right? And what could those be? So we will go to this table first, 8.5 and then 8.6, and we'll understand that. What are the drug-free therapies, for example? So many people take help from acupuncture, magnetism, Reiki, hypnotism, herbal products many people use like, black cohosh and ginkgo, ginseng, St. John wort particularly also to get relief of symptoms, and natural hormones such as phytoestrogens, clover mein hota hai, and then natural progesterone gel is there, but that is again to be taken care कि ये सारी चीजें जो हैं have been used historically as well, but इस पे कितनी research हुई है is a question mark. So I would not be very confident prescribing these, right? And then table 8.6 is the non-hormonal treatment for vasomotor symptoms. Beta blockers and all these drugs have been used for controlling vasomotor symptoms. These are chemicals, but not hormone, because then there is a whole different world of hormone replacement therapy, HRT, that has been the mainstay of the treatment for menopausal symptoms for decades, right? Its use has always attracted controversy initially in its promotion as a drug. हमेशा debate में रहता ये, but that's by large this is the most widely used treatment for postmenopausal women. Okay, right. Now, what are the different types of HRT, hormone replacement therapy? Think of it like this. What hormones are lost? So estrogen, for example, is lost, right? So, well, you would notice that I'm always writing estrogen this way. I like American system more. Perhaps I'm there. And this is the British system, right? Anyways, bear with me for that. Means the same thing. Spellings are different. American, British styles are different, right? So, what is reduced? Estrogen, for example, is reduced in menopause, right? So you have to replace estrogen. So hormonal estrogen replacement therapy. Estrogen is a hormone, so hormonal replacement. This is a group of hormone with estrogenic activity. If estrogen is given with progestogenic opposition, there's a high risk in time endometrial hyperplasia and cancer may develop. Systemic estrogen only HRT is suitable for women who no longer have a uterus following hysterectomy. So this is an important point. Now, when you are giving hormone replacement therapy, they come with risks, even so serious as much as a cancer can happen. Okay, so you need to see agar koi hysterectomy hui hai, then this is safe to give. Estrogen with progesterone, administration of progestin is necessary to protect the endometrium in women who have not had hysterectomy. क्योंकि अगर आप फीमेल को जिसमें hysterectomy नहीं हुई हुई सिर्फ estrogen दिए जा रहे हैं without the counterproductive progesterone, there are chances of getting cancers, as I just told you. It is normally given cyclically in patients over a 28-day cycle, of which 16 to 18 days will provide estrogen alone and 10 to 12 days will provide estrogen plus progesterone. That's how it's given. Estrogen and progesterone may be given continuously to women who are known to be postmenopausal over the age of 54. There are usually preparations with the same dose daily. So this is about the dosing details. Several types of progestins are used in the HRT by different manufacturers. Obviously, there would be. So the bottom line is decide if you are okay to give only estrogen or you have to combine it with progesterone, as you do in most of the cases. Okay, so estrogen only and progesterone, these are the estrogens that we use, these are the progesterone that we use, available in different combinations. Okay, right. Also, testosterone was going down, right? All the androgenic hormones are going down during menopause, so this is also the levels are going down. Testosterone has traditionally been given to women with disorders of sexual desire and energy levels who fail to respond to normal HRT, so this can be given. And route of hormone therapy, there are two main routes of HRT. Either it is oral or transdermal. This is the most common one. Oral route is normally a daily tablet. पूरा 28 दिन तक लेती हैं females. The oral route is convenient and cheap, but it does influence lipid metabolism and coagulation system, right? Transdermal route, either given as patches applied to the skin, on the tongue, or as major amount of gel. So this has also been used. Less effect on lipid metabolism. Progestin in the form of levonorgestrel may be administered as an intrauterine releasing system. So all these, but I think most commonly that we use are oral and transdermal patches. इनके beneficial effects, they improve the vasomotor system, they improve skeleton big time, because osteoporosis का risk reduce हो जाता है इससे. They help the lower genital tract, so vaginal atrophy and dryness and irritation, they are all taken care of. So जो major symptoms थे for the menopause, they are all controlled by hormone replacement therapy, right? But you have to be careful with the increased risk of cancer. Cardiovascular system also have beneficial effects because you continuously now give estrogen, which is cardioprotective. Okay, colon पे भी effect है. Now there are studies, clear benefit of HRT on incidence and mortality of colon cancer as well. So they're good, right? Prescribing and side effects. So things come with side effects, right? Prior to prescribing HRT, it is important to weigh up the indications, proposed benefits, and potential risks. For example, hormone therapy may be contraindicated in a patient with prior breast cancer or thromboembolic, because if you're giving this, you are increasing the risk of these cancers and thromboembolic event. In general, side effects of HRT are fewer and minor, and their benefits are more. But you need to weigh them kind of very carefully. कि कोई contraindication तो नहीं है. Absolute contraindications include जिसमें आपको किसी सूरत HRT नहीं देनी है. Okay, they are suspected pregnancy, breast cancer, endometrial cancer, active liver disease such as hepatitis. These hormones are controlled and metabolized by liver. Thromboembolic events known. These are absolutely never give HRT in these patients. Please be very, very careful about this, okay? Relative contraindications where you can give, but with caution and care, are fibroids and blind breast disease, and you can read them. Then side effects associated with estrogen are nausea, leg cramps, headaches, and progesterone, K fluid retention, and breast tenderness, and all these things, right? Easy stuff. Most side effects can be managed with a change in the dose of estrogen. So you have to monitor the patient. It's kind of a patient's body need to be, calibrated with the dose that you are giving for estrogen and progesterone. Risk of hormone therapy, the risk attributed to HRT have attracted much media attention. Well, I don't care about media, I care only about my patients. What is good for my patient, what is bad for my patient. So cancer risk. Breast cancer is without doubt the cancer that attracts most concerns from patients and most attention from world's media. The studies performed till do not fully inform patients of the additional risk they have because of HRT. Endometrial cancer and ovarian cancer are not considered significant risk with HRT use. Endometrial malignancy risk is largely eliminated if women are given progesterone. So you have to be a nice physician. You need to know that if I only estrogen दे रहा हूँ, then there are chances that I'm increasing the risk of endometrial cancer. But if you combine, and this knowledge is there, so if the knowledge is there, you do the best practice and you save the patient. Okay. Cardiovascular disease and stroke, as discussed, most of the HRT on the cardiovascular system given to a younger female are beneficial rather than causing events. But I mean, they can also have thromboembolic event and chances of a stroke. This is a possibility. Venous thromboembolism is known risk factor for hormone replacement therapy. So key learning points. Menopause is a key time in life of a woman, obviously a very important landmark. The physiological changes that occur have significant effect on women's health as a whole. Care of women during the post-reproductive years should be managed in a holistic fashion, taking care of the personality changes, psychological changes, and the organic symptoms the female will have. HRT exists in a variety of different forms, estrogen only, progesterone only, combination, oral, transdermal. The potential use of HRT in prevention of various diseases should be known, and the contraindications and risk factors. Okay. Mrs. A 36-year-old woman, she has had one child delivered normally and 6 years previously after a brief period of subfertility. Following delivery of that child, she had 4 years of infrequent period, and over the last 2 years she has been amenorrheic, 2 साल से amenorrheic है, and has had difficulty sleeping, often waking up feeling hot. So 2 साल से amenorrheic है, seems like secondary amenorrhea, and 2 साल से है, तो I would be inclined to make a diagnosis of menopause. And then there are menopausal symptoms as well. Hot flushes भी हैं, night sweats भी हैं. Likely diagnosis, there is menopause, but चूंकि age 36 की है, तो premature ovarian insufficiency, premature ovarian failure. Okay, how would you confirm the diagnosis? Because इस age bracket में है, I will do the FSH and LH. अगर ये low है, then it confirms the diagnosis. Following the diagnosis, she asks what are the immediate and long-term issues, and so you discuss with her all the long-term, intermediate, and immediate issues. Okay, एक question और करते हैं यार, कोई देखते हैं कौन सा है. Let's do this one. With regard to the hormone changes that accompany menopause, which of the following is true? So let's go through the options. As ovarian function fails, serum FSH level increase. Actually, this is true. Initially, it increases, but then once the ovary is shut off, then the levels go down. So I will park this as the right answer for now. Let's see what are the other options. 12 months after the LMP, serum levels of testosterone close to zero. No, they are not close to zero because there is peripheral production from adrenal, for example. So the levels are reduced, but not zero. So this is definitely a wrong answer. Secretion of GnRH from the hypothalamus increases significantly. In the late menopause, no, it decreases. So this is a wrong answer. Progesterone levels are undetectable in perimenopause area. No, they're not undetectable. They go down, but they are not undetectable. So that's the wrong answer. High levels of peripherally produced estrogen reduce the frequency and severe hot flush. No. The estrogen peripheral production is very subtle and it is not enough to control these symptoms. So this is also the wrong answer. This perhaps is the right answer, right? So if you read it here as well, FSH rises in response initially, but later on the overall levels fall.